when you have frequencies as a tool. So you treat downstream because the patient really wants their belly to stop hurting. But that's pointless unless you quiet down the midbrain, reduce the stress response, turn down the sympathetics, get the vagus working again, and then you can work on the gut.
I'm Garrett Salpeter, and I believe that the most powerful and transformative way to help people recover from pain and injury, heal from trauma, and reach their highest levels of fitness and performance is to focus on the nervous system. In this podcast, we'll share knowledge from the frontiers of neuroscience and inspirational stories of how applying that knowledge has empowered people from all walks of life to heal, adapt, and grow. Welcome to this episode of the Undercurrent podcast. I am ecstatic to have Dr. Carolyn McMakin here, and you may know her as the author of The Resonance Effect and the literal textbook on frequency-specific microcurrent. She has been the pioneer leading the charge in frequency-specific microcurrent for the last 20 plus years, has certified many thousands of practitioners, and many in our community here in the NeuFit community of practitioners have gotten interested in FSM, have started implementing it in recent months. And to have Dr. McMakin on here is just really a treat. So I'm very excited. Thank you so much for joining us.
Thank you, Garrett. The feeling is mutual. It's always fun working with people who understand the effect of current and frequencies on biological and neurologic tissue. That's my favorite thing.
It's mine too. So that's a great segue. Segue to dive in here. So can you just to kind of frame this up for people who have more or less familiarity with your work, can you start with just at a high level describing for all of us what FSM is?
It all started 20 some odd years ago, probably 1995. I got a list of frequencies from an osteopath who bought a practice in 1946 that came with a machine that was made in 1922. And that machine came with a list of frequencies. He walked into this practice in 1946. The machine was in a back room covered up with a sheet. He takes the sheet off and says, "What's this?" And started working with it. And I met a group of people that were his patients and his colleagues. And one of them went down to California, worked with him for 3 months, and then brought the frequencies back, literally written on pieces of typing paper, and stuck them in a drawer in 1983. In 1995, he found the list. We had a precision microcurrent that's 2 channels, and the list is organized with frequencies to neutralize certain pathologies or conditions like inflammation and scar tissue and histamine reactions, nerve trauma, and a list of frequencies for tissues. And there are, in our core class, there's maybe 150 more tissues than conditions, virtually every body system. And so in 1995, I started treating myofascial pain and with George, with the chiropractor that got the frequencies from Van Gelder. 96, I started treating myofascial pain. 97, I started teaching it to find out if it was reproducible. 98, we figured out literally by trial and error, because all I had was a list. I didn't know if any of these frequencies would work. They're all below 1,000 hertz. I didn't know if they work. So once I found out that they worked, then we had to find out if they were reproducible. Well, I'm a fee-for-service practice, so I can't do placebo treatments, although we did a number of those, portions of those, like the machine would be turned away from me. I didn't know what was running. I didn't know if the machine was on. We did that for 6 or 8 months. So I taught it in 97, 98, we started treating nerve pain. 99, we started treating the spinal cord and brain injuries, asthma, any condition that involves inflammation. So the over the years, well, first it was simply clinical science. It was science. It was you do this and that happens and you observe it. And then when you can, you measure it. And then you do this and that happens again when the conditions are the same. And then you do this and you can predict that that will happen. And then you have to teach it to find out if it's reproducible. So the model we had in the early days was probably not correct. The model we're using now, which is finally testable, is that the frequencies appear to change cell signaling. So on the outside of every cell, well, first, the body is a semiconductor because of the way that water flows in between the fascia and inside the blood. If you read the fourth phase of water, you'll find that the flow of liquid inside arteries and veins creates a conductive current. So anyway, so every cell has receptors on the outside. They're just covered, hundreds, thousands on the outside, little protein receptors that are, I think of them like antenna. And the thing that we had to explain was when you use the frequencies for toxicity, for example, the effects of the toxicity go away. Liver enzymes go down, the effects of certain toxins on biology change, but the patient doesn't have a detox reaction. They don't get sick, they don't get whatever. That meant, and this is clinical again, clinical experience, that meant the toxin had to already be gone, right? So if we were actually liberating toxins, then the patient would have a detoxification experience and would be sick or uncomfortable. They don't. So what was that about? And we lived with that for 10 years. Then one of the practitioners in Australia is an MD with a great mind for research. And what we came to was that these receptors, when an organic chemical gets embedded in the membrane, these receptors get cattywampus. They get into an abnormal configuration. Now the toxin over time is leached out and removed, right? But the receptor is still not in the right place. It's not normal. What we think happens, and the only thing that makes sense based on the clinical response, is that the frequencies reset the receptor. And the receptor is connected inside the cell to kinases, transcription factors, DNA, messenger RNA, which we've all heard of, but microRNA actually does the business of the cell. It creates the proteins. So by changing the receptor, we modify the cell function, or the frequency actually resonates with something inside the cell. Right now, I'm attached to the receptor model. For example, we treat gastrointestinal disorders, Crohn's, irritable bowel, inflammatory bowel, ulcerative colitis, as long as there's not an active infection. SIBO, we treat all of those things. And patients say, well, I've had this for 10 years. Okay. You don't have a single cell in your digestive system that was there, well, 4 days ago up till 7 days ago. There's not a single cell that hasn't been replaced in your gut. So how is it you have this condition for 10 years? Only thing that makes sense is that the receptors on the outside are modified so that they express the genes for inflammation or histamine. And when they get reproduced every 3 to 7 days, they're reproduced in the abnormal configuration. The frequencies come along and change the receptor, and that changes what the cell produces. So it's a reasonable model. It's testable. We haven't found anybody that's willing to test it yet. Every facility or university that I've talked to that has the capacity to do that kind of research wants more money and bigger projects that are university affiliated. So we have a little bit of a issue with getting the research, but that's how we think it works, is by changing cell signaling.
Interesting. So one of the most fascinating parts about this, you mentioned you have a list of approximately 150 frequencies. Some are related to functions or actions. More of them are related to specific tissues. So, ultimately one of the concepts in resonance is how specific frequencies resonate with and impact specific tissues. And one frequency, that what affects one tissue won't affect another. Is it through that mechanism? Is that what you think? Is that certain frequencies will stimulate receptors of cells that are part of certain organs or tissues and not others? You think it's a receptor-based mechanism?
That's the model we're using now. It's the only thing that matches what we find clinically. So you get an idea of what the problem is. So 22, 3, 4 years ago, I treated the muscle. We would treat, like neck pain, low back pain, we treat the muscle. Over the last 10 years, it has become apparent that you have to treat the cause. The muscle is never, 100% of the time, is never the problem, unless the muscle's been hit with a bat or cut with a machete or a scalpel or something. Muscle's never the problem. So I'd have an idea about what the problem was, and it didn't work. Over time, it took 5 years and about 40,000 patient visits before I understood that the frequencies always do exactly what they're alleged to do, but only what they're alleged to do. So 2003, I was in the Oakland Raiders training room, and Keith Pine was treating a player that had a hamstring injury on Sunday. Keith treated him on Monday, and I worked in the training room on Tuesday. And Keith said, I have been treating inflammation in the tendon for an hour yesterday, and it doesn't work. It's like, okay, well, let's feel it. Well, when you palpate it, the tendon's fine, but you slide off the tendon and there's a bursa. A bursa is like you guys know what the bursa is, right? Okay. So you slide off the tendon, you put your fingers on the bursa, and the patient flinches. Football players never say ouch, right? Their muscles react. So it's like, okay, now the frequency for the tendon is 191 hertz. The frequency for the bursa is 195. It's 4 hertz difference. And how somebody in 1922 decided that 191 was the tendon and 195 was the bursa, completely lost when the AMA made the use of frequencies and electromedicine illegal. The grandfather died, his library went away. If any of you have ever cleaned up your grandparents' or your parents' homes after they pass away, what do you do with his library? It's full of all these funky things. So all that research is lost. I have no idea. So I'm a clinician, clinical researcher. And so I slide off, and there's the bursa, and it's like, well, let's treat inflammation in the bursa. Bursa goes away. Now that the tissue's soft and pain-free, you follow the tendon down, and where the tendon attaches to the periosteum, that makes him flinch. Well, periosteum is very well innervated. It's like innervated felt. So we ran inflammation in the periosteum, and it was done. Keith treated him the day before for an hour. Keith was really good with his hands. And it didn't work. You had to treat the right thing with the right thing. So over time, that has become apparent. So you have somebody with rigid lumbar paraspinals. The quadratus lumborum is like a brick. And so you mash on the muscles and you get a little bit of softening, and you treat the muscles and it works a little bit. over time, we found that the cerebellum will inhibit the motion of any muscle that is adhered to a vital tissue or to a nerve. Like, it's not negotiable. The cerebellum is a complete dictator, and you don't need to know what it's doing or why. So after 10 or 12 years of frustration, I happened to find out that the patient had a history of kidney infection. So I was treating the kidney for inflammation, infection, scar tissue, and the QLs relaxed. And then there's a fat pad that's like a catcher's mitt between the kidney and the quadratus lumborum. So fat doesn't scar, it's sclerosis. So we treated scarring, sclerosis in the fat pad. And then kidney infection also causes inflammation down the ureter. So treated the ureter and the psoas for scar tissue, and everything turned to pudding. And this is all trial and error. So my ideas about what should work don't determine what works. The frequency response is completely predictable. And the cell signaling model is also supported by, when we treated fibromyalgia patients who had fibromyalgia associated with spine trauma. That paper was published, took us 5 years because nobody wanted to hear that fibromyalgia was curable. So we had 54 patients, and they have full body pain, pain in their hands and feet, pain in the shoulders, elbows, hands, hips, knees, full body. And the very first patient was in 1999. And the only thing that would create full body pain was the spinal cord, I thought. So I treated inflammation in the spinal cord, and it worked. Well, then after a year, I lectured at NIH, and we got data that showed us that all of the inflammatory cytokines produced in the spinal cord went down by factors of 10 and 20 times in 90 minutes.
That's amazing.
It's impossible. Yeah. Most of you know that, you obviously know that cytokines, when they change with medical treatment, change slowly over 1 to 3 months, if they change at all. This was a 10 to 20 times logarithmic rate reduction in 90 minutes. And they all stopped in the normal range when the patient's pain was 0. So the patient came in at an average of a 7.4 and left at an average of a 1.4 after 60, 75 minutes. And they all stopped in the normal range. It took 10, 15 years for groups of us around the country to come up with a made sense, because all of those cytokines are produced by cells in the spinal cord in response to signaling that changes what the cell genes express. Substance P is made in the spinal cord, transported to the periphery. Substance P went down by a factor of 10 times in 60 minutes. That's not possible. So the cell signaling model is the only thing that explains it. But it just makes it really fun, because at this point, the fibromyalgia from spine trauma patients are everybody's worst nightmare. You can't touch them. Their pain level is out of control. You give them enough gabapentin to get their pain down, and they can't remember what their car keys for or stay awake. So that's how we've developed the model and how the treatment has gone over time. Tendinopathies. So tendon injuries, you described your ligament injuries.
Yeah.
After I got my hip replaced, left hip, I started walking more. And within a month, I developed a Achilles tendinopathy on my left Achilles. I treated it with inflammation, chronic inflammation, all of the things that should make that tendon not be inflamed. And it just kept getting worse and worse. I treated it for 10 months and just finally gave up and wore a cane. And my tendon was the size of two thumbs next to each other, exquisitely painful. We were at a medical meeting and at the exhibit booth, and one of my practitioners was there with me, and she said, "This feels yucky." I said, "Can you treat it?" She said, "Yeah." So she chose the frequency for torn and broken. Now I have no idea what this frequency does. It doesn't make any sense, even with the cell signaling model. Torn and broken combined with the tendon. And the pain started to go down immediately. The contacts that she had, she was using the graphite gloves at the time, contacts she had got warm. And in 60 minutes, the tendon was normal size, completely pain-free, and never needed another treatment. It was done. That is a very good look on your face.
That's amazing.
It's like, okay. So then we started experimenting with this torn and broken. For me, it was a flyby. I never used it. So now we use it, well, in the shoulder. Somebody has a shoulder repair that doesn't go well. This was an actual thing that happened. It's one of my practitioners. He said, "The shoulder repair on this side went great. I had this repaired a year ago, and I've got trigger points everywhere in my shoulder." Well, they repaired the supraspinatus tendon, and they did it laparoscopically. So I felt his shoulder, and it was literally, the trigger points in the muscles were like cat litter. They're everywhere. Can't be the muscle. He's an expert trigger point therapist at Jefferson Medical School, PT department. And I thought, let's try torn and broken in the tendon. I ran torn and broken in the tendon. Muscles relaxed, the trigger points disappeared. And then I got some more history, and I felt around, and the surgeon had missed a tear in the teres. There's a partial thickness tear in the teres. So I ran it for an hour. Trigger points are all gone. The shoulder's pain-free. You have to take the scar tissue out between the subscapular nerve and the subscapularis muscle. And then I said, just run this on yourself an hour a day for the next 4 days and try not to break it again. So where we've evolved to in the last 20 years, it's never the muscle. You always treat the cause. So in the cervical spine, you treat ligamentous injuries, you treat facets. In the upper cervicals, you treat adhesions between the nerve and the dura, you treat discs in the lower cervical spine, and that relaxes the muscles. We think it's the muscle because that's what you can feel with your hands. So the physical therapists and the PM&R doctors and the chiropractors that are listening, it's never the muscle. You have to use the frequencies to treat the cause. Why is the cerebellum making the muscles tight? What is it trying to protect? Right? Doesn't come from space. The cerebellum tightens the muscles to protect the joint, the ligament, or the disc. It tightens the QLs to protect the kidneys. The kidney and the ureter are adhered to the fascia. Is the cerebellum going to let you move that muscle if your ureter is glued to it? I don't think so. It's not negotiable. So over time, and we're talking thousands of hours in patients and mistakes, I'd like to go back and retreat everybody I treated in 1997 through about 2005. Dissolving scar tissue, I don't know how it works. I have an idea, but that doesn't mean it's real.
Well, can you share with us your idea? I mean, that I'm interested in that. Actually, you talked about the that mechanism of toxicity, about how by getting the receptor, you're changing without having to excrete the toxin in the same ways we traditionally think. So yeah, It
So
seems like you're not mechanically pulling apart scar tissue. So how are you energetically? What's your hypothesis on that model?
what appears to happen, if you think about scar tissue, I'm really glad we decided to do video on this because I use my hands. I'm Italian. I can't actually talk without my hands.
Well, for the people who are listening, I'll try to describe your hand motions too.
So if you take a rubber band and you know how you wind it up and it winds and winds and winds until it winds down on itself and it's double and triple wound and it's really short.
Mhm.
That's what scar tissue is like, but it's collagen. And there's little cross links that hold these coils of scar tissue together. They're cross links. My idea is what appears to happen is the frequency resonates with the bonds that hold the cross links together. So every biological tissue is made up of molecules, atoms, and subatomic particles, right? Your arm, everything is biochemicals. Every mechanical structure and chemical structure is held together with electromagnetic bonds, right?
Oh yeah.
So when a singer sings a note that matches the binding energy that holds lead atoms together in a 70% lead crystal glass, she sings that note. It has to be precise, exactly that frequency. And she has to hold it at that frequency for long enough that the lead atoms vibrate and they just come apart because they're vibrating in response to the note that is being projected to them. So what happens with scar tissue, there are a set of frequencies that loosen scar tissue. My first experience was in a burn unit, thanks to Bart Flick. I went to Mercy St. John's burn unit in Springfield, Missouri in 2003. And we worked on chronic burn patients, all full thickness burns, the most difficult kind of scar tissue, 8 patients. And every single one of them had, so the PTs measured them Monday, Friday, and then every Friday for, I think, a month. Every patient had statistically significant increases in range of motion after 3 one-hour treatments.
Wow.
Yeah. So that was burn scarring. We've since worked on more burn patients, one in Taiwan that was just spectacular. The kid had 80% of his body burned in a fireworks accident. His clothes caught fire. And his elbow was stuck in, I think it was about 15 or 20 degrees of flexion. He couldn't straighten his arm. And I treated him for an hour. And at the end of that hour, his elbow was straight. The skin doesn't look the same, but the underlying connective tissue. So scarring works best when you're treating the connective tissue in skin. In abdominal adhesions, you treat the adhesions between the organs and the peritoneum are made of connective tissue, but then you have to treat the scarring between the organs. So in somebody with endometriosis, irritable bowel, Crohn's, inflammatory bowel disease, ruptured appendix, whatever, the sigmoid will be glued, let's say, to the peritoneum on the left, but the sigmoid can also be glued to the ovary, the tube, the bladder, the uterus. And you just peel all those apart. And the nice thing is that in general, it doesn't seem to come back. So then, and you have other questions on my list, but it's the interesting outcomes.
If you're ready to supercharge your practice, listen to this. Garrett and Team NeuFit have just released a new online course entitled Introduction to the NeuFit Method. In this detailed 8-hour course, you'll gain mastery of the fundamental techniques in our practice, including muscle testing and activations, nerve glides, and joint articulations. You'll also get introduced to our patented direct current stimulation device, the Neubie, an incredible machine that's empowered professionals just like you to help their patients heal, adapt, and grow faster than they ever thought possible. To learn more, go to www.neu.fit/learn. And now back to the show.
Well, one of the things here that I think is really interesting, and just you've already shared, of course, this range of, helping people with, chronic disease and myofascial pain, and in even intractable cases like fibromyalgia and your tendon. It's so cool. And that story that you told with our mutual friend Keith Pine about working with the football player, in that story about, you can discover, well, it's not the tendon, it's the bursa, and then you can say it's the periosteum. So one of the things that I think is so interesting is that there's almost this diagnostic component. There's this theme emerging that, like, you can guess and check. You can hypothesize, I think the QL is tight because of a disc. And if you treat the disc and it doesn't work, then you try the next thing. You say, oh my gosh, no, it's because of scar tissue, from a previous kidney infection or something. So there's like a diagnostic component. And we speak a lot in our NeuFit community about trying to get to the root cause and finding why muscles are tight, or why there's a perception of threat that's triggering pain. So to be able to do that, and is that something that you speak about in your curriculum, that there is sort of a diagnostic component to it?
Yeah, that's it. It's as you go through the curriculum, one of the things that turns out is, and like I said, it took me 5-6 years and about 40,000 patient visits to figure out that the frequencies never don't work. So in that respect, they're diagnostic. Mm-hmm. Probably 40% of the class is diagnosis. How do you tell if it's a disc or a facet? Well, muscles hurt worse if it's a disc when you flex forward, if it's a facet when you bend back. So that tells you what to treat. The range of things that you never had to think of before. So if the only thing you can do is put a needle into it, it doesn't matter what caused it. Mm-hmm. The only thing you can do is put your elbow in it, or your thumb, or give them a pill. It doesn't matter what caused it. In our world, patient is picking pears in Uncle Ralph's orchard, and he's had shoulder pain ever since. So you could treat the tendinopathy, that didn't work. Treat the muscle, that didn't work. Did Uncle Ralph have an organic orchard? Oh no, he sprayed at the very last minute because the whole family goes down and picks pears, and Susan hates spiders. And so this year he sprayed as late as you can. Okay. So you have a man with trigger points like cat litter in his shoulder, and maybe there's a little tendinopathy. But you ask him questions about how does he metabolize alcohol or caffeine, find out his liver doesn't do those very well. So you already know that he's not going to metabolize organic chemicals very well. So you treat toxicity in the fascia, and all the trigger points disappear. So you have to think about it took me 20 years to figure out that the class I have to teach is not frequencies. You can look those up. They're on a list. The list is useless. I have to teach you how to think, mm-hmm. how to think about how pathology and the nervous system, I got to get to this because we're almost done here, how pathology and the nervous system work together. And how they can be influenced, how you have to think about that in order to achieve an optimal result. So, for example, and you have to, everything you know, everything you've learned in your career comes in handy. So we had a patient if you read the resonance effect and you read chapter 10, in there is a case report from the neurologist that was at this class. This kid had been a pedestrian hit by a car in a coma for 3 months. When he was 22, he came to the seminar when he was 28 or 29, and he had the most ferocious intention tremor. Like he had not been able to hold a cup or take a cup to his mouth in 8 years. So intention tremors are associated with the basal ganglia. So we treated the frequencies to increase secretions in the basal ganglia, the spinal cord, the nerve. Used 2 machines, one to run the basal ganglia, one to run the spinal cord. And intention tremor completely went away. Smooth, pointing, the whole neurologist is sitting there doing this neurologic exam. And then I said, well, we really ought to connect the sensory cortex to the basal ganglia to make the motion intentional and smooth. So I ran the frequency to increase secretions in the sensory cortex. And the tremor came back and was way worse.
Wow.
And I looked at the neurologist and said, Steve, what did I just do? He said, you overwhelmed the ability of the basal ganglia to handle the input from the sensory cortex. Quiet down the sensory cortex. So there's frequency that quiets down that activity. So we quieted that down, increased secretions in the basal ganglia, and he was back to smooth pursuit. Treating stroke patients, you increase the secretions in the sensory and motor cortex, drive it down through the cerebellum, drive it down to the spinal cord. And there are frequencies that do this. It's in the neurologic section of the course. And then the really cool part is when you're working on an extremity, like especially shoulders, but any extremity that's been painful for a long time, you fix the peripheral pain. The active range of motion goes to normal. Pain is 0, but there's a hesitancy. The movement is not coordinated. To move the shoulder, there's 9 or 10 muscles that have to fire in an exact order. Who does that? Cerebellum. So you increase, so you get the shoulder normal, then you increase secretions in the cerebellum. And then it will move normally, but it's like the patient can't find it. All the input from that shoulder stops in the thalamus because there's been so much pain involved. Well, the thalamus is the pain center. It's part of the midbrain. The thalamus, the hippocampus, and the amygdala all work together to teach you not to do that again because that hurts. So there's a frequency that quiets down the thalamus. And so that's like afraid to move it. The symptom is the patient is afraid to move it. Quiet that down, and then increase input from the sensory cortex, increase input from the cerebellum, spinal cord, movement returns to normal. So what would normally take 6 months to 18 months happens in 2 weeks. You fix the peripheral. It's been amazing. And what we're doing with the nervous system just knocks me out. Thalamic pain, like from strokes. Knock on wood. So far, we haven't found anybody it doesn't work on. Like, that's impossible. Post-operative recovery, speaking of Keith Pine, Keith got me started with Oakland. I ended up working with San Francisco. I followed Terrell Owens to Philadelphia, and he had an open spiral fracture in his fibula, tore all the ligaments in his ankle, had a plate and 2 screws put in. I flew out to treat him immediately after surgery because he wanted to play in the Super Bowl in 6 weeks.
I remember that. Eagles, Patriots.
That's it.
Yeah.
And McNabb doesn't like getting sacked, and the offensive line was having a bad day. So Terrell did really well, but it was supposed to be a career-ending injury, and we had it We had it done in 4 weeks. And the frequencies to remove scar tissue are so powerful, I wouldn't use them till we got to Jacksonville. When he got to Jacksonville, he couldn't run. He ran 20 yards in his lower leg spasm. So we spent 5 hours, Brian Glotzbach and I ran the frequencies, Brian used his thumbs, and we took apart Terrell's lower leg and his foot, took apart all the scar tissue. My cat rack adjusted it the next day, and Friday he ran like he'd never been hurt. That's impossible.
And when you say you waited for the scar tissue, you waited to apply it till you were at the site of the Super Bowl. Is that because you wanted to have some natural scarring as it healed, and so you didn't want to block that process because you do need some scarring, and you didn't want to make it unstable? Is that your thinking, or?
Well, that's the other trial and error part. I found out that after a new injury, through trial and error, you have to wait till 6 weeks to take apart the scar tissue. The body needs repair tissue to be laid down in order to heal the injury. And then we can thin it out and take out the abnormal scar tissue in, 2 or 3 hours instead of 18 months, because normally the body would remodel it with use. And it's like, yeah, we'll just help you along with that. And so far, it doesn't take apart scar tissue that is required. It just takes apart the scar tissue that you don't need. So it's the multitude of uses. Treating neuropathic pain is just easy. Nerve pain is just easy. Neuropathic atrophy. So if somebody has thenar or hypothenar atrophy caused by a disc in the neck, it's easy. First time I did it was 1997, and I didn't believe it. And now it's like, oh yeah, we can fix that. Yeah, that isn't arthritis in your thumb. That's a C6 nerve root. Here, look. And in 20 minutes, it's gone. You still have to strengthen the muscle, but you can resolve the neuropathic pain. Emotional stuff. There's a list of frequencies for emotions, right? Hurt feelings, anger, resentment, grief, terror, right? There's 970 on channel A, and then these organs associated with these emotions in channel B. And they're all mediated by the nervous system. So the midbrain, the hippocampus, the amygdala, the medulla, all cooperate in giving you the experience you have of an emotion. But once you have frequencies that address the emotions specifically, you learn how they're layered. So woman loses her child, and her presenting emotion is grief. We learned this at a seminar. A woman came as a student. She lost one of her children who had a genetic disease. She took him to the ER, told the doctors what was wrong. They wouldn't listen to her. He was dead by morning. And so grief is the presenting emotion. That's acceptable. My students got around the table during the practicum, and the Good Samaritans ran the frequencies for grief. And this woman is just weeping, tears running into her ears and all of that. And I walked over to the table and I changed the frequency from grief to anger. Anger is not acceptable. Grief is acceptable. She was furious at the doctors. So I ran anger, resentment. She has another child with the same genetic disorder, terror. And then we could run grief, and there were no tears.
Wow.
So the frequencies, and I have a master's in counseling that helps me think about these things this way. Football players do not have emotions, but they have hamstring injuries that don't resolve. So you treat from the low back to the knee, you do your muscle work, but you run the frequencies for fear and hurt feelings and the tendinopathies, but the emotional component, they don't have to talk about it. It just works.
Mm-hmm.
And it helps resolve components of some of the conditions that you see. Working on abdominal adhesions in a patient that's been raped is completely different than working on abdominal adhesions in a patient who has irritable bowel, right? The emotional component between the two is different. And the midbrain is always associated with the emotions. And these days, we treat the vagus all the time.
Mm-hmm.
So the vagus nerve is turned off by infection, stress, and trauma. And the vagus nerve controls the immune system and your vocal cords and your digestion and your swallowing and your bronchi. And in cervical spine injuries, the vagus gets glued, gets scarred down. So the vagus, we think of it as being from the chest down. The vagus is like a spider web in your neck. There's a branch of the vagus that goes back up into your skull and innervates the back part of the dura and blood vessels. There's stretch receptors. Vagus controls your blood sugar. It's amazing. So we treat the vagus when it's appropriate.
Mm-hmm.
So welcome to my world.
Well, it's fascinating, and I'm so grateful to you for sharing all of that. One last question, because there's just such a wide range of use cases that we've covered, and circumstances, injuries, illnesses, conditions where FSM is able to help make profound changes for people. So one question that, especially for people listening who haven't yet used FSM with any of your devices or ours, there's this kind of notion of like a lock and key, for example. You talked about resonance and certain frequencies. It's like if you have a key and you have a door that's a fascia, ligament, disc, bursa, kidney, you got to find the right key for that. How do you know, for those listeners who haven't experienced this yet, does the opera singer ring down from the sky and the glass breaks, or do you have to wait an hour and see how someone responds, or how do you know when you're on the right frequency that's actually affecting somebody? I think it's important that we cover that before we say.
There's actually a published paper about that. Jim Oshman wrote a paper, tissue softening. So we call it smush. Mm-hmm. But if the frequency is correct, the tissue, it's a very light touch on your part to be able to perceive it. But the tissue everywhere will soften if the frequency is being used anywhere that is correct. So it's actually why 50% of the seminar is about differential diagnosis. How do you know where to start, right? It's like you have 600, the advanced course, the core seminar has 2 columns on 2 sides of 1 piece of paper. The advanced course is 3 columns on 2 sides of 2 pieces of paper. There's hundreds of frequencies. So the course has evolved, thank God, to how to think about conditions and tissues and illness when you have frequencies as a tool. So you treat downstream because the patient really wants their belly to stop hurting. But that's pointless unless you quiet down the midbrain, reduce the stress response, turn down the sympathetics, get the vagus working again, and then you can work on the gut. There's one place where we don't use frequencies, and that's one of your questions I want to get to before we stop. We don't treat cancer, period, end of discussion. It's not safe. We don't have enough data. If I make a mistake, and I have in the past, and I make your pain worse, it's inconvenient, but it's going to go back down, and it affects the quality of your life, not your life. If I do something out of ignorance or just lack of data, that makes your cancer worse, you may not have time to get back on top of it. So we don't treat cancer. The frequencies we have for infection are really helpful once the infection is cleared up. They're also helpful to help diagnose the infection. So the patient comes in and they're coughing, and so you run the frequencies for pneumonia, and everything gets warm and the patient gets sleepy, and then you stop and you tell the patient you're going to urgent care and you're going to get antibiotics. That's end of discussion. I had one patient that was like that, and she was one of those that wasn't going to take antibiotics. So I called her husband and ratted her out, and he took her to urgent care. We don't treat infection. We don't treat fatal disease. So sleep apnea. Everybody wants to know, is there any way I can treat sleep apnea that doesn't involve a CPAP? No. There's a book called The Promise of Sleep by William Dement. He's a medical sleep study expert. You read that book and you become absolutely convinced that sleep apnea is a fatal condition. Doesn't matter what else you have, sleep apnea is what is going to kill you. So we don't treat that. We don't treat cancer. We don't treat infection. And we can clean up the mess afterwards. If they're on antibiotics already, we can treat that. We can treat radiation burns. We can treat the side effects and the nausea from chemotherapy. We can treat the pain from bone metastasis. We can treat terminal patients that have refused standard medical care or failed with it. We can keep the pain down. But it's as important to know what not to treat as it is to know this myriad of things that you can treat.
Yes, absolutely. With great power comes great responsibility.
Amen.
And it's amazing how you've really been a trailblazer in this new field and trained many thousands of people. And in many ways, you're an inspiration to me and what we're trying to do with NeuFit, to take a new treatment model and really change the face of treatment and medicine, at least in our, obviously we're focused more in, neuromuscular in this realm, and FSM extends beyond that. And we're really excited to start incorporating FSM and learn from you. And so for the people in our network here in the NeuFit Nation who want to take your courses or read your books or learn more about you, how can people listening find you online or in the world?
Probably the best way to get an idea about what FSM is and how it was developed is the resonance effect. That's available on Amazon. And then our website is frequencyspecific.com. The courses are listed there. It used to be a 3-day course, then it was 3.5, then it went to 4. And now it's a 5-day comprehensive, but then we split it into 2 3-day modules. One is a pain and injury module, which sounds like it's what would suit your folks. There's a neurovisceral module. You really need the neuro section to be able to treat the pain and injury part optimally. But that way you have less financial and time commitment if you do the 3-day modules. And they're all on video. This year and last year, we went to live stream, and they're all available on video. I'm writing questions right now for the 5-day course so that it's a course. You take it 90 minutes at a time, answer 10 questions or 15 questions, and then you go on to the next module. So it's a process. The webinars in the last 2 years have turned out to be our continuing education. So I've got a webinar on Ehlers-Danlos. Ehlers-Danlos went from being impossible to I just love seeing them walk in the door. They're so easy to treat. You fix the connective tissue, turn the vagus back on, quiet down the midbrain, and it lasts a week. And it's a genetic condition. How it works, I have absolutely no idea. But there's a webinar on Ehlers-Danlos, on mold, on strokes, on the unique respiratory virus. And just that's how we keep in touch. Is I'll do a webinar every month or two, and with slides, and it's usually case reports of patients that I've treated. So it's like with your community, the NeuFit Nation. I like that. With me, I'm Italian, so it's the FSM family. So yeah, so that's how you start. And if your device can be modified to include our frequency range, because like the basal ganglia is above the range that you do use, the emotional frequencies are above the range, even the sympathetics are above the range. So yeah, the device company has to be completely separate, because the FDA, I can say things about the frequencies that can't be said for the devices. The devices are approved in the category of TENS devices for the symptomatic treatment of pain conditions, but there is no position from the FDA about the use of frequencies. So I'm a clinician reporting to other clinicians the effect of my clinical experience, and that gives me a lot of latitude. The devices, yeah. So it's a separate company for the devices, but the training is the important part, because you just think about it differently. So, for example, if somebody has a denervation condition like AFM or any place like RSD or CRPS, anything where the peripheral nerves are disconnected from the peripheral tissue, anything you do to that peripheral tissue gets converted into pain in the thalamus. So you have to be able to do both, right? So it's how you think about it that changes once you have a tool. So you have the tool, and your students and your network are very enthusiastic, the ones I've met, and I would be happy to have them incorporate FSM into what they're already doing with your device. It's outstanding.
Fabulous. Yes, we have had several mutual colleagues, who have the Neubie, the NeuFit device here, and have gone through your training. And thankfully, we can do most of the frequencies. But yes, we are working on some modifications to be able to add additional ones.
Outstanding.
And for I know that on some of our mastermind calls, those who have actually gone through your training have been raving about how it's complemented what we're doing, and how it's helping them work in an even wider range of cases. And that's part of why we're so excited to introduce this to our family, to our nation here. And
Well, I'm glad they find it a good compliment. One of my watch phrases is, my job is to make your job easier.
Yes.
More effective, more efficient, less expensive.
I like that. I think that's a good note on which to say goodbye. We want to make everyone who's listening here, all the practitioners, make your jobs easier and more fulfilling and rewarding and exciting by being able to provide the tools and resources and knowledge to make the biggest impact possible. And Dr. McMakin, you've been doing that for 25 plus years in the FSM world. Thank you for the work that you're doing, and thanks for coming on and sharing it with all of us.
Oh, thanks for having me. I appreciate it. Take care, guys.
Bye-bye.
Thank you so much for listening to the Undercurrent podcast. If you enjoyed this episode, please consider leaving a review and be sure to subscribe to stay up to date as we release future episodes.